Good morning, everyone.
Just wait 1 second. I think there's another thing she has to do.
Done.
Are we good for both?
Yes.
Okay, go ahead.
Good morning, everyone. For Montiar today, our guest is Dr. Sebastian Ludwig from Hamburg, Germany. Dr. Ludwig is a real expert in the field of transcatheter mitral valve replacement, in general in transcatheter mitral therapies. He was the first one to design a multi-center study, the choice on a dedicated device on transcatheter mitral valve replacement, and I'm sure he will show some of the results of the research he has done on that. And since the design of this study, he published so many articles, so hopefully this won't be extremely long, this talk, because he has really a lot to say about this. He also, just on the side of this, he spent a year with us in Montefiore and CRF, where he did even more research. And he's now a good friend of us, and this is why we welcome here in our Montiar today. Go ahead, Sebastian.
Thanks a lot, Andrea. That was really nice. I wouldn't actually call myself an expert, but I'm honored that you that you find myself an expert, and I'm really honored to be invited here for to give a short talk on TMVR at Monty Hart. Yes, what can I add to what you said? It was really.
Well, it's always a pleasure and honor to have someone who is our fellow who then becomes one of our speakers. So it's very exciting, and we're very proud of you, Sebastian.
Thanks a lot. That means a lot. So without further ado, I'm opening my presentation, if that's okay. Okay. So yes, I've been asked to give a talk on TMVR, current status, future perspectives. I mean, you could probably talk about this for hours, but I'm trying to really focus on the most important things. So if we talk about treating MR, maybe just to start with the basics. Where does TMVR stand at the moment? So at the moment, it's really not recommended by guidelines, because probably also of the current status regarding studies, regarding evidence. So if we're dealing with primary and secondary MR, of course, we have surgery and TEER that are both recommended by guidelines. For secondary MR, we also need to treat the patients with guideline-directed medical therapy optimally first. If both of these therapies or all three therapies fail or are not an option for these patients, either clinically or anatomically, we then can consider TMVR. And I've kind of lied saying that it's not recommended by guidelines. It is actually, it's mentioned in the guidelines, in the European guidelines, that it can be considered with a 2B recommendation in patients that are not suitable for surgery or TEER. So this is that. So why do we need TMVR? First of all, talking about surgery, we've all seen these slides. Why do we need alternative therapies to surgery? Because many of our patients, you can see this on the right, are elderly patients, 65 years old, 70, 80 years old, or even above that. And mitral valve disease is very common in these patients. And if we look on the left side, the reasons why surgeons do not operate patients in general are mostly age and comorbidities. So these are, of course, very prevalent in elderly patients. So we kind of need, it's pretty obvious that we need alternative therapies for these patients. Of course, we have TEER, and there is a lot of evidence on TEER. I'm not going to talk about this. And we know that TEER also has its limitations, especially when we were talking about surgery. The limitations were mostly clinical, age, surgical risk. When we're talking about TEER, it's mostly anatomical. So there's this classification: green, yellow, red. You can add some colors if you want, but it's mostly three categories. With one category, the red category, categorizing patients as unfavorable candidates for TEER. Mostly these patients have concentric MAC with stenosis, small mitral annular area, a lot of calcification, clefts, multiple jets. So really complex anatomies. You can treat these patients, but it's complex, and they are at risk of suboptimal outcome. Some of these anatomies are summarized here. I don't want to go into detail. But why is this important? Why are these patients not really suitable for TEER in the end? Because they are at risk of residual MR and mitral stenosis after clipping, or after if we don't want to concentrate on clipping, after putting a TEER device in. And we know that residual MR and stenosis are associated with adverse outcome. At least for residual MR, we know this pretty well for both primary and secondary MR. For mitral stenosis, it's not very clear. We've just one of our manuscripts has just been accepted in JACC intervention on the impact of intraprocedural gradient and residual MR, showing that there might be, as you can see below, a correlation between gradient and outcome, especially in those patients with very high gradient at the end of the procedure. But in the end, it was not really significant, and the impact of residual MR especially was much greater. But at least there seems to be some kind of adverse risk with mitral stenosis, and of course, residual MR is extremely important. So TMVR for these patients offers actually what we need for these patients. So it offers something that we can offer patients at high or prohibitive surgical risk and patients with unfavorable TEER anatomy. And what are the main pros of TMVR? Of course, we don't need cardiopulmonary bypass. We can eliminate MR in these patients, and at least in theory, the therapy is agnostic to valve anatomy. This is extremely important because we need something that we can offer patients that are unsuitable for TEER with MAC, all the things I've just told, and on the other hand are at high surgical risk. And at the moment, there's not really a treatment option for these patients. On the negative side, or on the con side, this therapy is associated, and we know that of our from our clinical experience, that these patients can develop LVOT obstruction because most of the devices, they protrude into the LV, they interact with the AML. Many of these patients, especially those primary MR patients, have small ventricles, and they tend to develop LVOT obstruction, and this is really has really a high risk intraprocedurally and postprocedurally, of course, and many of these patients die eventually. So this is really important, and you have to exclude this. And I'm coming back to those exclusion criteria later. Other cons or negative side disadvantages of this therapy are, of course, bleeding risk, because all of these patients need to undergo anticoagulation. On the other hand, you put a prosthesis in, and of course, this has the risk of thrombosis. So bleeding risk, thrombosis risk. This is something that you have to consider, and that you, of course, don't have to worry about if you treat patients with TEER. So now, what are the devices that are available at the moment? One device that is implanted transapically is actually currently available. It's the Tendyne device, has been implanted a lot, especially in Europe. And there are many, actually, those are the most important transfemoral devices. There are others under investigation, but those are, maybe if you focus on the most important devices, the most important devices. But it's very important to say that all the transfemoral devices, although this is probably the future that we're looking at, are currently under investigation, and none of these they are all far away from FDA approval or CE approval, and there's only one device that has CE approval, which is actually the Tendyne device, which is implanted transapically. I think the Tendyne device has actually also FDA approval in the United States for patients with MAC. But this is actually all that we can offer patients on a daily basis without including them in studies. This is so. I mean, Andrea already told you about our registry that we put up together with Leonard Conradi, who's a surgeon at my clinic in Hamburg, and Thomas Moudin, who's from Bordeaux, and Walid Ben Ali, another surgeon from Montreal. So I am actually the only cardiologist in this group. So we put up this registry initially designed for patients that undergo TMVR screening, because we had this the issue of high screening failure rates in these patients, and that we want to consider for TMVR. So we want to find out what are the reasons for the screening failure. But eventually it has developed, because I'm going to talk about the first manuscript a little later. But it developed actually to registry of TMVR patients treated with dedicated devices, which is actually the largest registry on this topic so far. And you can see on the left side that we included more. Now it's more than 400 patients. Back then it was 400 patients, most of them with transapical devices. Actually, most of them also treated with the Tendyne device. But we included actually all available devices within studies, if available, but mostly compassionate use cases. So actually all data we could get, we included in our study, and you could probably call this an all-comer study, probably, or all device or device independent study. The study was international. We included 4 centers, including your center in Monty from the United States. Most of the centers came from Europe and 1 from Australia. This was a manuscript that we published last year in Eurointervention on the 2-year outcomes after TMVR, and we showed actually what all the preliminary studies, small studies with the TMVR showed. And what is the main advantage of TMVR? It's MR elimination in most of the patients, and this works. We know that now. We proved that many times. So if we treat patients with TMVR, MR is eliminated in 90%, 93%, or even more. But on the downside, and you can see this below, if we look at MVARC outcomes or 30-day complication rates, these are elevated, especially if you compare that to TEER. We have a lot of patients with bleeding complications, 11%, which is a lot. Mortality rate is 9.2%, which is way too high if you consider new treatments for these very elderly patients. Access site complications are high, and these patients tend to have acute kidney disease. So this is mortality of 2 years, 38.1%, also high. But if you see this curve, you see that it's rising in the beginning, and then it seems to reach some kind of a plateau. So if you look at this from a logic way, this has to do something, must have to do something with the procedure, because it's only happening within the first 30 days to 3 months after the procedure. So the question is, does this have to do with transapical access? We included most of the patients with transapical access, only few with transfemoral devices. We did another analysis in this study analyzing the impact of 30-day complications on 2-year outcomes, and it actually confirms what we were thinking, that major bleeding complications and major exercise complications, which has to have something to do with transapical access, are one of the major impact factors for 2-year outcome, or one of the most important associators, or most important predictors of 2-year mortality. If you compare this to the data that we have coming from the studies with one single device, it shows the same. As I've told, MR elimination in most of the patients. On the left side, it's Tendyne. On the right side, it's Intrepid, the transapical cohort, published this year. It shows MR elimination in almost 100% of the patients, but on the other hand, exactly the same, actually, the rise in events within the first 30 days to 3 months after the procedure. And remember, these are transapical procedures. So this is the theory, that the risk of the procedure, probably associated with the access used during the procedure, leads to an elevated rate that persists, of course, after 2 years or even more. So the question is transfemoral access the solution, or or does it even work to treat these patients transapically? Yes, it does. There's now a lot of data coming with few patients, preliminary or pivotal studies, or even smaller studies. These are data from the HiLife device that was published last year, including 30 patients, or the first 30 patients that were treated with this device. It also confirms very good MR elimination. And the death rate, if you look at the death rate, it's much lower actually than those rate that we saw with transapical devices. But there's also something of concern, at least in my opinion, which is the high bleeding rate. It's also about 17%, and you can see this in my upcoming slides. This is something that we can see with all, or at least many transfemoral devices too. So bleeding risk kind of persists. Just a couple of words on the HiLife device. It's a transfemoral device. You use transfemoral and transeptal access, but you also need transatrial access to put a ring below the mitral valve annulus to create a landing zone. This is just a very short summary of this device. So it's not only transeptal access, you also need transatrial access, but it's not large bore access. You need it just for the ring. This is actually the best data that we have so far on transfemoral TMVR, and it comes from the Intrepid device by Medtronic. This was published also last year by Dr. Zar from Seattle, and I think it's Seattle. And it shows actually very low mortality after 1 year with only 6.7%. It's only 31 patients, and they, of course, there's one of the criticisms that you can always see. Of course, these patients are very well selected, but there is no data so far on TMVR showing that low mortality rate after 1 year. So I think this was really impressive. On the other hand, also confirming again what we saw with TMVR and all other TMVR devices: MR elimination in about 90%, functional improvement, and so on. And this device, just 2 sentences or 1 sentence, this device is also implanted transfemorally, transeptally. You don't need a ring for a landing zone because it works with radial force. Yes, yeah, I think that's it. Now moving on. I've already told you the high bleeding rate that I wanted to confirm in my upcoming slides. This, you can see 24.2% major vascular complications. The bleeding rates aren't included in this table, but they were high as well. I think about 30% or even more in these patients after 30 days. So bleeding rates, access site complications still is an issue, although it's not transapical anymore. And at least in this study, it doesn't really translate into inferior outcomes after 1 year. Now, all the other devices that I'm showing now haven't really published a lot of data on their devices so far. This is something that is kind of a out of the box thinking. The AltaValve device, which is also implanted transeptally, but it's not a device that is implanted and protruding into the LV. It's implanted in the left atrium, which kind of addresses the risk of LVOT obstruction, which was a major exclusion criterion for all of the TMVR devices so far. And these are some data that have been published. Low all-cause mortality, or acceptable all-cause mortality after 30 days, and low bleeding rates actually, but also high efficacy. This is the Cephea valve by Abbott. This is one of your patients that has been treated. Thanks again for the video. There are some data that have been published on compassionate use patients by Augustin Kwan, another colleague and friend of us, showing good survival after 1 year and low complication rates. It's also a device that is implanted transfemorally, transeptally, working with radial force and anchors, kind of, or spikes that ensure stabilization. And this is the last device I wanted to show, the M3 device by Edwards. These are very old data from 2019 by John Webb. After that, there was nothing coming from this device. I haven't heard anything. However, it seems that they are pretty far with their study, and this might be another device to consider in the future. So this device is actually a SAPIEN 3 valve implanted in the mitral valve space. You kind of create, similar to the HighLife device, you create a landing zone by implanting a ring in the subvalvular apparatus. And after that, you put in the valve, which has a code, so it's coded. So it's not exactly a SAPIEN 3. This is why it's called M3. But in the end, it's a valve-in-valve procedure. So this is really something's interesting, and something I find interesting too is that by implanting the ring and catching the anterior mitral valve leaflet, you kind of ensure that these patients do not have LVOT obstruction. At least this is the theory. So I'm really excited about seeing results of their study probably very soon. I told you that I wanted to talk about the choice MI registry because this is something that we're still dealing with. And today, also with transfemoral devices, it's patient eligibility, mostly anatomical patient eligibility. These are the very first TMVR data that we collected. We collected first data of 267 patients, and we then looked at were they accepted for TMVR or had they screening failure, and after screening failure, how were they treated? I don't want to go into details, but you can see that most of the patients, or 70% of patients that we are currently, or that we were back then referring for TMVR, were declined access to TMVR because they didn't fulfill the eligibility criteria, 70%. If you look at the screening failure rate that is published, this is actually in the middle. Some say it's 60%, some say it's about 90%. I think 70% screening failure rate is still what we experience in our daily practice. I'm excited about what you telling me about your US experience so far, or at the moment, or if it has changed, but this is still at least what we experience in Europe. If you look at the screening failure reasons for these patients, the most important one was annular size. But the second most important is the risk of LVOT obstruction. This is still a major issue, and ventricular size, kind of the reasons 2 and 3. In my opinion, this is one reason. So the interaction of the device with the LV, creating LV obstruction, creating risk of myocardial interaction, and so on. MAC was the fourth reason. I think this reason does not apply anymore to all devices, because there are devices right now that are especially focusing on patients with MAC. There are large cohorts included in the Apollo trial with the Intrepid device that look only at MAC. There is a MAC cohort in the Summit trial with the 10-9 device, and there are devices that especially looking for patients with MAC, like Cephea and so on. So MAC has become something interesting, and this is also something that we found when looking at this study that I wanted to show you. This study, using our choice MI anatomical screening data, looked only at patients that screen failed and were then treated medically. So in the end, those patients that we cannot treat at all at the moment, these are actually the patients that, in my opinion, innovation has to look on, and where we really need devices. So we looked at these patients and then tried to define or find clusters of anatomical, clinical, echocardiographic parameters, how to characterize these patients. And we found, and I think this is extremely interesting, we found 2 clusters. The first one, this is phenogroup 1, was consisted of patients that were women that had primary MR, that had preserved ejection fraction, that had a lot of MAC and high gradients. And I think that this cohort is the cohort that innovation, that new TMVR devices have to focus on, because these are the patients that we need treatment for, because for these patients, we don't have anything at the moment. For all other patients, TEER might work, surgery might work, also, or there might be some other way to treat these patients. But for these patients, there's really a gap of treatment. So in summary, before I want to maybe if we have time after that, I can show you some more slides on choice MI propensity score matched analysis. But now a summary on TMVR. Of course, there's a need for an alternative MR therapy for patients at high surgical risk that are unfavorable for TEER. TMVR, and I've showed you that, is not only ensures predictable but also durable MR elimination, which in theory has to be or is agnostic to valve anatomy. But all the studies that are available right now show early mortality and post-procedural complications that might, be associated with transapical access. The first results, especially the results with the Intrepid device that are published, are very promising with transfemoral devices, but we need more data. It's only 30 patients. That's really not enough to draw conclusions. And patient eligibility remains a major concern for these patients. So if you look at this journey of TMVR, the first implantation was in 2012. So in 2012 with the cardiac device. And until now, these are all devices that have been tried, that are under investigation, and only one has obtained CE mark, which is the 10-9 device. And all the other devices are now under investigation. There are studies going on, and it's all looking promising. But still, if you look at this, you have to say it has been quite disappointing so far. So what's happening now, or what has to happen for TMVR to become standard therapy at last, which is what we all hope for, that we can offer these patients something. We have to overcome transapical access. I think this is pretty obvious. We have to reduce periprocedural complications also with transfemoral devices, and we have to improve anatomical eligibility. I think this is a no-brainer. And just to end, we tried with the Choice MI registry, because we included a lot of TMVR patients, to find the current place for TMVR within all the therapies that are available. So we tried to compare our data, although this is difficult because, of course, there's a selection bias. These patients were treated with TMVR for a reason. So it's difficult to compare this to another therapy from another cohort, especially retrospective and observational, but still we did it. And I think the results are pretty interesting. So we compared our TMVR cohort on secondary MR to the GDMT, so the medical cohort from the COAP trial, which we know did very bad against TEER in the publication. And we showed two things. We showed first, TMVR was associated with functional improvement and a reduction of heart failure hospitalizations on the right. It was not associated with a reduction of mortality. Remember the curves between TEER and GDMT, they differ a lot. In the COAP publication, they did not here, but I think this is an important finding, that at least there's a sign that TMVR is associated with some kind of a benefit regarding heart failure hospitalization, and at least no harm regarding all-cause mortality if you compare it to medical therapy. We then did the same comparison using data from the EuroSMR registry to compare TMVR to TEER, also for secondary MR. But please, without looking at the Kaplan-Meier analysis, first look on these graphics on the right side, which is really summarizing the main differences between TMVR and TEER, especially regarding MR treatment. When you implant a valve, MR stays the same and it's stable until the valve doesn't function anymore. But the valve will function at least up to 1 year. This is what we showed with almost all patients staying at none or trace MR, or at least one MR 1+. Whereas if you treat these patients with TEER, you are at high risk of developing residual MR and recurrent MR after 1 year. And this is extremely important, especially in patients with secondary MR, because the LV is growing and it's an ongoing disease. The Kaplan-Meier analysis showed what we expected, an almost significant difference between TMVR and TEER. TMVR showing lower mortality rates. But if you exclude the 30-day events, which is the post-procedural phase, there is no difference after 1 year whatsoever. And I think this also confirms what I've said before. We have to reduce peri-procedural risk, and we have to look at transfemoral access. And this is the last data that I've just presented at New York Valves last week. Really focusing on the cohort of patients that is at interest for clinicians and for patients, which is the red zone anatomy cohort with primary MR, so complex anatomy that is difficult to treat with TEER. We did a propensity score matching using data from the Prime MR registry and our registry. We showed that there was a difference regarding mortality still in these patients. Transapical access, the impact of transapical access or access site complications seems to be larger than the benefit of MR elimination, at least in this preliminary data. But regarding all-cause mortality or heart failure hospitalization, so looking at a more a softer endpoint, there was no difference whatsoever. And we also did a comparison between TMVR, transapical and transfemoral, although very few patients. And we showed that the difference persisted in transapical TMVR against TEER, but not in transfemoral against TEER. And maybe this is something nice to conclude with for this presentation. Though we really, we have to look at transfemoral devices in the future and to overcome transapical access. Thanks a lot.
Thank you, Sebastian. This was really a great state-of-the-art lecture on transcatheter mitral valve replacement. You covered everything. Based on what you said, we need to move from transapical and go forward with the transfemoral, percutaneous transfemoral access. This will help reducing the complications. What I think will still be a significant difference with transcatheter edge-to-edge repair that you compared in some of the studies. So basically the mitral clip or the Pascal device is bleeding, because this patient will still require anticoagulation. So bleeding will still be higher in this group of patients. We need to see if this is clinically significant, important, if this is associated with some clinical outcomes. And also a question I get for you, I know you did so many studies, you couldn't show everything, but we are implanting this device, this valve in the left ventricle, and most of these are also interacting with the subvalvular apparatus. So it is logical to think that this will impact on the function of the left ventricle and or the left atrium. Do you have anything to say about this?
You mean on the interaction of the implanted valve with
yes, the response in terms of left ventricle and left atrium. You also published something on the hemodynamics. I don't know if you want just to cover.
Yes, I mean, yes. Thanks, Andrea. I mean, this is a great question. We indeed just published something very, observational with very few patients looking at hemodynamic impact of TMVR, and we showed that there is some kind of hemodynamic remodeling, but there's also an increase in left ventricular pressure, which seems a little concerning. And we interpreted this as, kind of an afterload mismatch. So you reduce MR all of a sudden. So the ventricle has to pump against the higher aortic pressure now. So this is why we interpret this as a result of MR elimination. So on the other hand, we showed that the ventricles were smaller in the end, and the contractility was better. So the overall performance of the ventricle was better. So there are positive and negative sides. So I'm not really sure if we can already say that eliminating MR to zero is what we should aim for, because when looking at TEER. When looking at TEER, the data show that actually, sorry, can you have to close?
Yeah, we can hear you.
Yes. Okay. Sorry. So when looking at TEER, the TEER data, actually it shows that reducing it to mild could be enough. So eliminating it to zero, there is still a question if this is really necessary. I think it could be the less the better, but it still needs to be shown. And regarding left ventricular remodeling, there's not really data to support this by right now. The 10-9 data didn't show really LV remodeling, and all the other studies also did not really show LV remodeling. Those were mostly secondary MR patients, so we know that the disease, so the left ventricular disease, is ongoing. So these might be, the wrong patients to look at. But it's this is going to be, I mean, it's a very important question. It's we have to look at future studies.
So Sebastian, as you were presenting, I kept wondering, oh, why didn't you show me curves for transfemoral versus transapical? And then right at the end, you showed me why you did it, is because you have too small numbers. And I think that's something we all have to concentrate on, is increasing the numbers in the CHOICE MI registry of transfemoral, so we can really understand how much is related to access, right? And to the transapical. I think the data from the Intrepid transfemoral cohort is really impressive. 0% 30-day mortality, 9% at 1 year. We've not seen outcomes like that low, right? So I think we got to learn more about that. I think we also got to learn more about sort of the predictors of mortality in these patients. I think your 2-year multivariable is really interesting, that the patients who have complications are most likely to do poorly. So, can we eliminate some of those 30-day complications? I wanted to ask a couple of questions, though. So talking about afterload mismatch, in this large group of patients, have you actually been able to document true afterload mismatch? So patients who got the valve and then just did poorly afterwards with chronic heart failure, needing inotropes or hemodynamic support?
Not in our registry, because the data is not granular enough to look at this, so we didn't really look at afterload mismatch. There are some patients that did poorly after the procedure, but we don't know why, and we didn't collect data on that. But look in our clinical practice, there are some cases where this happens, and you cannot really explain why the patient does so poorly hemodynamically after the procedure. And this, in the end, the only explanation for us is it might be afterload mismatch then, but it's there's no real not real really good predictors for this, I think. I don't know what
I agree. Right. And also I'm starting to learn that there are two types of it as well, right? There's the patient who, like, immediately after the procedure, you see the ejection fractions now, like, they started at 35, it's now 15, right? Because that's the true EF. And they're really struggling immediately post-procedure. They need inotropes, they may need a balloon pump. Then there's these others, which is actually more painful, is the ones who actually do okay, they go home, and then they just have this chronic worsening heart failure and low output state afterwards. And those are just like very depressing, because they end up on inotropes on permanent inotropes until they die, right? And it's just, their heart function just cannot tolerate with the fact that they don't have this pop-off valve. So the one thing I was wondering as I was listening to your presentation, I mean, to me, it seems that this is mostly in the secondary MR group that this happens. In the primary MR group, usually the EFs are normal, right? Most of them. You just showed even those phenotypes. So in the secondary MR group, I mean, have you looked, and I'm sure you had, but maybe I missed it, is there, like, when it comes to mortality and outcomes, a graded response depending on EF? So patients who have like 30 to 40, 40 to 50, do they have different outcomes? And also patients with different LV dimensions, do they have different long-term outcomes?
It's super interesting, and of course we looked at it. We didn't pursue it because there were no differences. It's the painful truth, because we wanted to do something on LV remodeling. We tried to look at different EF stages. We looked at different LV dimensions, different outcomes. The outcomes were the same, and my explanation always is that the impact of the procedure is, with these data that we have so far, just bigger than the impact of, you know, any LV remodeling or functional benefit or a benefit of MR elimination even. So I mean, I can only support what you said. We need more transferable data in our registry, and I think with these we will eventually be able to show you know, which are the patients that benefit most from this therapy.
Right, absolutely. Sorry, go ahead, Andre. You want to go ahead? I see there's Tanya, Antonella, and Afon.
Yes, I know that Dr. Ludwig has to run to see his patients, so maybe we can briefly give the last questions. Tani, do you have any questions for Dr. Ludwig?
Good morning. Thank you so much for giving this excellent talk. It was very interesting. I just had a couple of questions. First, I wanted to ask about as far as differences between the TMVR and the surgical valves, is there just the anatomic patients or that we're still missing? Are they also missed in the surgical patient population? Like, is this just a patient population that we're entirely missing in our ability to treat? I'm just trying to understand, like, if there's some difference in the valves that we're making from TMVR standpoint versus what we're able to do surgically.
I think that's a great. Sorry, I'm hearing myself double now. I think that's a great question because it addresses, you know, the importance of surgery. That we know we're talking about interventional treatment of these patients. Sometimes it might be a good option to, you know, consider surgery even in these patients. But most of the patients, I think this is also true, are 80 plus, have a lot of comorbidities, and, you know, are just not fit for surgery. Even if we wanted to, you could treat them surgically probably, and the procedure might go well. But these patients have a high, very, very high peri-procedural, post-procedural complication rate and mortality rate. Even more if you consider MAC. You know, these patients that with MAC, these are, you know, the surgical nightmares. If you are surgeons, you really have to, you know, cut out the whole calcium. It's very traumatic. In the end, you have to reconstruct the atrioventricular, you know, the curtain. And this is you know, in Europe, at least some surgeons in our clinic, they call the UFO operation, because you don't really know where you're going, and you know where you're coming from. So it's really a black box. So I don't know if as I've said, if you consider surgery, it's about clinical criteria, not really anatomical. But if you want to talk about anatomics, I think MAC is the most important exclusion criteria also for surgical valves.
Okay, interesting. So it's very much the mitral valve anatomic heterogeneity that's like causing us problem on all ends, it seems.
And you got to remember also, Tani, you know, a lot of majority of the patients we see are actually surgical turn-down patients. And so we've been trying to percutaneously design valves for patients who are surgical turn-downs, but that's not where we started. We just tried to design valves that would anchor in a mitral apparatus, which is very complex to start with because it's not circular, they're chords, it's dynamic, the size is larger. It's not, you know, aortic is so easy. It's a circle with calcium. And so it was much easier designing valves for the aortic, but the actual fact of designing a valve for the mitral that can eliminate some of the even with everything we know now, right? We know so much now. It's still so hard to be able to design a valve that can address the limitations of the current valves. It's because we have to put this valve into human anatomy, and that anatomy carries with it specific limitations that are difficult to overcome. And particularly, you know, when it comes to the two main factors for the reason we say no, which is size, okay, annulus is too big, or the risk of LV outflow tract obstruction. And even though we can cut leaflets now, it doesn't work for this issue, right? Because the valves are too large and they're covered, so you can cut leaflets as much as you want. It still won't prevent LV outflow tract obstruction.
Yeah, that's very interesting because, again, seeing in our lab and seeing our structural heart team work, it seems very much that the large bore access and how to do that, and kind of having to standardize equipment and delivery, we seem to have come really far. So as far as differences between aortic valve and mitral valve, I think, yeah, as you pointed out, it's that anatomic heterogeneity that's really a challenge from a design perspective. My second question was actually around this afterload mismatch component. I guess coming from like a heart failure mindset, there's a lot of recognition of like HFpEF, stiff ventricle, and the various phenotypes that exist around it. I mean, we're just beginning to understand kind of the genetic predisposition when it comes to like HFpEF physiology. So I wonder if there's any data in kind of comparing some of the outcomes for patients that deal with the afterload mismatch, if there's a HFpEF physiology component, like if they've kind of had exercise physiology testing or.
So maybe I can answer that. I mean, the only time we've really seen sort of acute afterload mismatch are in patients with a depressed ejection fraction, right? So low ejection rate. I mean, by definition, that's really been what we mean by afterload mismatch. We do so though see a lot of patients with HFpEF. What's been interesting is some of the data coming out of the Emory group, Sebastian and Tani, is that the Emory group have been doing something called the Sesame procedure, where they do a percutaneous myotomy to prevent LV outflow tract obstruction as a preparation for TMVR or for valve in MAC, all right? And particularly valve in MAC, because valve in MAC, there's a huge component of HFpEF. And what's been interesting is that some of the patients, when they come back in 1 or 2 months for their follow-up CAT scan, where now they're going to talk about doing the TMVR, say, actually, I feel a lot better now. I don't want anything done because my symptoms are a lot better. And I think some of that is probably having improved, to some degree, the HFpEF by making the slit in the ventricle, that the ventricle's gotten a little bit bigger, there's a little bit less outflow tract obstruction, there's less diastolic dysfunction. So I think we may in the future, that's a different subset, the HFpEF with mitral valve disease, and they tend to be patients with MAC. With a lot of MAC, they have high gradients across their mitral. I think that's a different subset we're still trying to understand because it's so heterogeneous too.
Perfect. Maybe we have time for one quick question. Antonella, do you have a quick question for Sebastian Ludwig?
Yes. Hi, Sebastian. We met last week. It was nice. Just one question. You show us that the main cause of for this patient to be ineligible is the annulus size. Do you think that is just a matter of size device? If they give you more sizes, this patient will be treated, or is the device characteristic that you cannot treat this patient anyway? I don't know if I'm trying to explain myself. Do you mean
yes.
do you need?
Yes, I think it's a great question. Thanks. I think when looking at the initial data or the patients that we initially submitted for TMVR, those were patients that we didn't have a treatment for a reason, and some of these were patients that we knew, actually, if we are honest with ourselves, that we knew that TMVR won't be a good fit either. I think you have to be that honest, because there were some patients that had just the largest LV, the largest annular diameters, all the smallest with a lot of MAC, and we basically knew that it will be very difficult, to treat this with the valve, even if you have a lot of sizes available. On the other hand, I think what you said is important too, because I think we are limited also by device sizes at the moment. So if we had more device sizes, larger or smaller, I think we could treat more patients. I think this is also the other other side of the medallion.
Excellent.
And just a confirmation, in this case for TMVR, you don't have any issues with conduction disturbance, AV block. There's not an issue, right? Usually.
Not really. We
Okay.
at least now in our hospital we didn't have any. I don't know, Azim, if you had AV blocks after TMVR.
When I've not had it with TMVR, but I have had it with Cardioband. Interestingly enough,
Interesting,
because when you go into the posterior medial trigone and you try and put anchors there, you can get pretty close to the bundle of his. So I've not seen it common, but I wouldn't be surprised with some devices that have anchors that are really pushing on the medial trigone, whether that's a possibility or not. Because I've seen it interestingly enough with Cardioband.
Thank you. Bye, Sebastian.
No, thank you.
Let's see if we have one last question from Manaf Asafin.
Yeah, Sebastian, thank you so much. That was a fantastic overview and really an impressive body of work that you've accumulated in this space looking at mitral, percutaneous mitral valve intervention. So congratulations to you. One of the things that I'm frustrated with a lot in clinic when I'm seeing mitral regurgitation patients that we can't treat with edge to edge is, as you mentioned, the difficulty in screening them for mitral valve trials. Last week, I had to turn a patient away after they screen failed from 3 separate trials. And it's tempered a lot of our excitement that we initially had about the mitral valve replacement procedure. So I guess as a sort of broad strokes question, I mean, do you think that this is sort of our fate in this space? This is an anatomically difficult space, and we're going to have to live with a screen failure rate of 70 or 75%? Or is this something that you think is going to get better as maybe devices change or our ability to modify the anatomy changes? And then as kind of a follow-up question to that, if you had to kind of envision in your mind a valve that would overcome a lot of these things, what would be some of the features that you would want to have in that valve? You mentioned transfemoral clearly being superior to transapical, but maybe some of the other features.
Dr. Asafin is very philosophical this morning.
Yes,
so he's really put you on there.
I knew that already. No, thanks, Manav. I mean, it's a very, I mean, especially the first part is a very important question, because I think if you look at all the trials of TMVR, especially the 10-9 and Intrepid data, those patients were mostly secondary MR, which aren't really the patients that we are looking at right now. That we don't have treatment for. That are TEER ineligible. Even if you look at, because if you look at the 10-9 inclusion criteria, and I think it's also Intrepid, TEER ineligibility I think it was not really necessary that these patients were TEER ineligible. They just had to be at high risk for surgery. So all the studies and all the efforts didn't really, I think, and this is what we experience right now, is they didn't really look at the right population. So the population that now the studies are focusing on are now the right, these are the right populations though. So I think we really have to wait for the data. Still, LVOT obstruction is always going to be a problem if you implant a valve, in the mitral valve protruding in the LV. So if we ask me, the LV protrusion has to be as small as possible. And I'd be really interested, to see more alta valve data too, because these patients, for these patients, LVOT obstruction is not a problem at all. And at least according to the company, you can implant this valve on almost all the patients, which is also probably not true, because they also have other exclusion criteria. I guess you experienced that yourselves. But yes, I think we have to still, look 2 or 3 years from now to see if the screening failures go down. I think at least I'd hope they go down by by some percent to something like 30 or 40%, which would be much better than something like 70 or 80%. I hope that's a good answer to your question.
It's a very difficult answer, and I think you gave the best response possible. It's challenging. It's really challenging.
Okay, I think we can conclude here. Sebastian, thanks so much from all of us for being part of Montiart as a colleague first and now as a speaker. I really hope we'll see you in the future again. You will give us another talk on another topic, maybe. Thank you. Thank you so much.
Thanks a lot for having me.
Thanks, Sebastian.
It's a pleasure, and I'm always
Thanks.
stay connected for always and forever.
Absolutely.
Have a good day.
Always part of the team. Take care, Sebastian.
Bye-bye,
Bye-bye.
guys.
Thank
Bye-bye.
you.
Thanks a lot. Thank you.